Hello, and thank you for joining the Donut of Destiny. This is a special episode sponsored by HeartFlow. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. And now a word from our sponsor. HeartFlow enables clinicians to see coronary artery disease. It all starts with a single CT scan. HeartFlow's AI-driven analysis then creates a personalized 3D model of the heart, providing lesion-specific physiology values and plaque quantification and characterization. To ensure your next clinical decision is the right one for every patient, visit heartflow.com to learn more. On to our episode.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. So I'm going to toss out some hot topics in coronary imaging: FFRCT, plaque analysis, culprit lesion identification. While today we may use each of these concepts in isolation when interpreting coronary CTs, the future likely involves a comprehensive approach, merging all of these concepts together to understand patient and lesion-specific coronary pathobiology. On today's episode, we dive into two recent studies, Emerald and Emerald 2. These studies investigated the interplay between coronary physiology and plaque morphology in the context of predicting acute MIs. My esteemed guest is one of the lead investigators of the Emerald studies, Dr. Bongkwon BK Koo from Seoul National University in South Korea. BK, welcome onto the podcast.
Thank Praveen for the kind introduction. I'm very happy to be here.
Excellent. Thank you very much again for joining. BK, before we begin, let's learn a bit more about you. What is your current role at your institution, and how did you get involved in cardiac CT research?
Good. So today we are going to talk about CT, but I'm not a CT specialist, but I am an interventional cardiologist doing invasive physiologies and coronary stenting implantation in the cath lab. But I've been working with the physiology for over 2 decades, but while learning about the physiology, I learned that invasive physiology have several limitations. The patient should be in the cath lab and should undergo the invasive assessment, which requires a high-cost devices and practices. So then I was thinking about the potential of using CT scan to assess hemodynamics, or specifically FFR, without invasive procedures and without adenosine and without expensive devices. So then I was involved in the CT scan around 15 years ago. And while learning and doing some researches about the CT-derived physiology, I learned that the combination of image and physiology, and I learned a lot from CT specialists that they told me that the importance of CT-derived plaque analysis. So then I was interested in combining physiology and plaque morphology and lumen characteristics, plaque characteristics, etc. So I am now deeply involved in the cardiac research with collaboration with the CT specialist and also from the companies working for the CT hemodynamics and plaque analysis. So that's how I'm here today.
Wow, BK, you are a master of many different things here, both in the invasive or interventional space, as well as in the non-invasive, or what we could call the wireless space. Many of us imagers use currently commercially available tools for evaluating coronary physiology, oftentimes with computational fluid dynamics-based tools. And we also use tools for coronary plaque morphology evaluation. But, these tools are often used in isolation from one another. There's one tool for physiology, one tool for plaque characterization. Basically, the physiology is often divorced from morphology when we interpret cardiac CT. So before we get into the study at hand, the Emerald study, I'd like to get your take on if these two things are related to one another, and if so, how are they related to one another?
Yes, I think that's a very important question to understand the ongoing studies and debates about the importance of imaging versus physiology. As I mentioned earlier, that I am from physiology, but now I'm trying to provide the data that show the benefit of combining an imaging and physiology. So the reason why is that when the plaque begins to develop, progress, transforming into the vulnerability, and finally into the ended up with the primary events. There's a endless interaction between blood or hemodynamics and plaque morphology, anatomically and characteristically. So that's how I have interest in combining imaging and physiology. And there are more than enough data showing that combining plaque characteristics and lumen characteristics in hemodynamics can improve our prediction ability for the future cardiovascular events, not only the soft endpoints, but also the hard endpoints. And there's also several reports showing that the physiology and hemodynamics and plaque has a kind of a complementary roles. So without analyzing both plaque and hemodynamics, I don't think we can reach our goal. So that's why, actually, that's the background of the Emerald studies. And I hope that the audience will understand this important concept. Combining imaging and physiology will be the best to do our job, to understand the following communications or discussions.
BK, I think this dovetails nicely into the main topic at hand, the Emerald and Emerald 2 studies, and how they perhaps unite these ideas of coronary plaque and coronary physiology on imaging. So let's talk about those studies in terms of the rationale and design. And let's take a kind of 10,000 foot level and start with the Emerald study first.
Okay, so that the Emerald study, which was published almost 6 years ago, was designed to show that addition of hemodynamics on top of lumen and plaque characteristics can improve our prediction ability for future ACS. So here I'd like to stress the importance of the primary goal of this study is not about soft endpoint and not about revascularization, but acute coronary syndrome. So in the Emerald 1 study, we started with the lumen and plaque characteristics, and then we added the performance of prediction ability of adding adverse hemodynamic characteristic, what we call that in relative to the adverse plaque characteristics, to show the benefit of the combining plaque and hemodynamics to better prediction ability for the Emerald 1. So that's the rationale and design for the Emerald 1 study. And Emerald 2 study is a kind of expansion of Emerald 2 trial. It's 5 times bigger than the Emerald 1 trial. The lesson we learned from the Emerald 1 trial was that at that time, we purely used the human intelligence. That means that we have to co-register all lesions manually, which takes several weeks to do a co-registration. And we also analyze the lesion hemodynamic characteristics, mostly manually. But we found that in Emerald 2 trial, we had to deal almost 2,500 lesions. Human intelligence and manual performance were not enough to analyze all those lesions. So that's we tried to incorporate the machine learning and AI to analyze all these things. So that the main rationale of the MO2 trial was that currently we have the very nice tools to analyze the CT defined lesions such as luminal narrowing, plaque burden. Also, the CT specialist or core lab can provide the very important information on the plaque, such as low attenuation, passive remodeling, Neptune ring sign, etc., etc. So we have the best human intelligence-based parameters, but that requires time, cost, and it has some limitation of intra and inter-individual variability in the interpretation. So in the Emerald-2 trial, we tried to the benefit of the AI-enabled quantitative plaque and hemodynamic analysis on top of the human intelligence-based core lab analysis to define or to predict the future risk of the ACS or acute coronary syndrome risk.
BK, there is so much to unpackage there, and I know that our listeners are likely in suspense to try to hear your take on the results of both, but I do want to ask just a couple of extra methodologic questions about Emerald and Emerald-2. In Emerald, regarding the plaque evaluation, was this done in a qualitative fashion to identify certain plaque morphologic characteristics, or was there a quantitative component in the first Emerald study to plaque evaluation?
So in the end, we had both quantity and quality, because that we understand that the quantity and quality, there's also some debate about the importance of quantity and quality, but I personally feel that the combining quantity and quality metrics together is also important than either alone.
Excellent. And to confirm, the physiologic method of evaluation, the wireless physiology, if you will, is based on a computational fluid dynamics model, correct?
Yes, so that we've done lots of researches on CFD-based or computational fluid dynamics-based hemodynamic assessment. And in both Emerald-1 and Emerald-2 trial, the most popular metric, fractional flow reserve of the FFR, and we feel that that's a very good parameters, but as we have to understand that the acute coronary syndrome is not a per-vessel event, but it's a per-lesion event. So we wanted to move into the deeper area about the lesion level hemodynamics. The simplest one was that the delta FFRCT, or the FFRCT difference across the lesion, and wall shear stress, axial plaque stress, so that not only the fractional flow reserve or FFR, we integrated the rather new concepts about on the lesion level hemodynamics into this both Emerald-1 and Emerald-2 trials. But both are the non-invasive CFT-derived hemodynamics.
Got it. So if I'm understanding correctly, the basic principles are from CFD-based FFRCT, but there are some unique parameters that y'all derived from CFD-based FFRCT, including wall shear stress, as you've described, in the results for Emerald-1 and Emerald-2.
Yeah, you're right. So, but the beauty of the applying CFT on CT scan is, so I'm an interventional cardiologist, so in the cath lab, if I want to measure wall shear stress, it will be killing me. I can measure it, but it requires several devices and lots of math and so on and so on. But when we run a full 3D simulation, it's not that difficult to extract the higher level or deeper level of hemodynamic information. So I'm happy to say in the end that the simplest metric, delta FFR, across the lesion is the simplest and the best metric. But if you want, you can analyze far more complicated hemodynamic indices.
Excellent. BK, I think that I just have one more methodologic question before we get to a brief review of the results. Were these retrospective or prospective evaluations? And to remind our listeners, the hard event that we're looking at here is downstream ACS, correct?
Yes, that's so true. So that in the beginning, I was thinking about the possibility of performing prospective studies, but I realized that it's almost impossible. It may be possible, but practically it's almost impossible to have a very simple prospective design. So the easiest simple prospective design is CT scan, collecting all the patients who have a CT scan and doing all these analysis and waiting for 5 years and to see how many patients will have acute coronary syndrome. But you know that during the elective CT scan or the CT scan taken at the stable coronary syndrome or the screening processes, the prevalence of the acute coronary syndrome is around 1% or less than 1%. So practically it's impossible. So we discussed a lot about the design issues. So in the end, it's similar to both ML 1 and 2 trials. In the end, we decided to screen all the acute coronary syndrome patients. So definitely acute coronary syndrome who visited the emergency room and underwent the coronary angio, having a definite coupled lesion for ACS. And among those, we retrospectively screened the medical database to find the patients who underwent the CT scan when they are stable, when they didn't have any symptoms for acute coronary syndrome. And we analyzed the CT scan and we divided the lesions on that CT scan, culprit and non-culprit lesions with the help of the core lab definition of the culprit lesion, and then we analyze the data. So it's a retrospective data collection and kind of prospective analysis, blinded analysis.
Fantastic. Okay. I think this is a great setup then for talking about the salient results from Emerald and Emerald 2. Let's start by talking about what we took away from Emerald and how those teachings kind of supported the design of Emerald 2. So, in your words, what would you say is some of the most important learnings from the Emerald study?
Yeah, in Emerald 1 trial, as I mentioned earlier, it was designed to say that using CT scan, we can predict the future risk of acute coronary syndrome. And the second thing is lumen information, plaque information, hemodynamic information. Will those be replaceable or complementary? So in the Emerald 1 trial, in the end, we proved that the addition of adverse hemodynamic characteristics at that time, it was defined as CTFFR, delta FFR across the lesion, wall shear stress, and axial plaque stress. And adding those 4 components, adverse hemodynamic characteristics, can improve our prediction ability for future acute coronary syndrome. So by summary, for Emerald 1 trial, this trial found that addition of plaque and hemodynamics can predict our ability in terms of using CT scan for future ACS, and we can develop some models and we can define some coupled lesion and treatment strategy according for that. And that's the key message from Emerald 1 trial. And Emerald 2 trial is much larger, 2,500 lesions. It's data collected from 9 countries. So in this trial, we tried to prove the benefit of AI-enabled quantitative and qualitative metric of plaque analysis in prediction of acute coronary syndrome lesions. And in this trial, we compared the core-lab-based independent analysis versus pure AI-enabled quantitative plaque and hemodynamic analysis, in which we used that the 8 plaque features and 10 hemodynamic features. And then we proved that the first, adding on top of the human defined in the plaque and lumen analysis, adding AI-enabled plaque and hemodynamic analysis can improve our prediction ability. And the more interesting thing is when you compare the human intelligence plus AI versus pure AI, there was no difference. And what is more interesting is when we simply compare the human performance versus AI performance, AI performance was better. So that having all those things together, I think that in the future, when you apply the AI-based analysis, it may provide us a better prediction of the future risk and better selection of treatment strategy for patients who have a coronary artery disease.
BK, this is fascinating. I want to summarize a little bit to make sure that we're both on the same page in terms of the primary learnings from Emerald and Emerald 2. From Emerald, we learned that there is incremental value to including non-invasive physiologic evaluation in predicting MIs. And that's such a great benefit that we have to these patients, is that we may improve our ability to identify culprit lesions that may be the cause of downstream MI by including a physiologic evaluation on top of what we're doing of looking at coronary CTs in terms of their plaque evaluation. And then from that, in Emerald 2, we recognize a further incremental value of including an AI-based evaluation of a variety of these different parameters in physiology and plaque quantification over just human interpretation alone. Is that an accurate representation?
Yeah. That's a perfect summary.
Perfect. Okay, great. From there, were there any discrepancies perhaps between our learnings from Emerald 2 and the previous learnings from Emerald 1?
I think basically it's similar, but if you read the papers, Emerald 1 and 2 trial, you learn that the concept on the features have been improved, but the basic concept has almost the same. But as you well summarized, that the MO1 trial was designed to prove the benefit of the hemodynamics, to say that you are the CT specialist, you know a lot of the lumen and plaque analysis, but if you have an ability to combine the hemodynamics, you can have a better prediction ability. And the MO2 has a kind of a rationale to prove that the AI-based analysis may make us improve our analysis for the CT scan.
BK, I've heard some in the quantitative plaque space make the argument that quantitative plaque analysis tools may make the need for lesion-specific physiologic assessment, for example, a delta FFR CT, less important. But that statement seems to challenge what we've learned from Emerald 2, right?
Yes, so that you know very well about the recent PREVENT trial, for example, which randomized the patients which have a obstructive lesion, high FFR or physiologically negative lesions and having vulnerable lesion in terms of plaque quantity and quality, and randomize the patients into the preventive PCI versus medical treatment. There was a statistically significant better outcome with the preventive PCI. So I'm not in 100% agree with that interpretation, but anyway, with those results, first people are becoming more skeptical about the physiology. And the second thing is that, as you just mentioned, that the plaque analysis versus lesion level plaque analysis. But one important discrimination between all those PREVENT trial and previous FFR based trial is that in those trial, what was used was that the per vessel index. FFR is a per vessel index. We are not taking an FFR value in proximal LAD lesion and mid LAD lesion. But what we are using in the ML2 trial and also in ML1 trial is that the lesion level hemodynamic analysis. And the question is that whether we really need an lesion level physiologic assessment on top of lumen and plaque analysis, because the CT collab and CT specialists can provide a 20, 30, 40. So when we ask the collab to provide the comprehensive lumen and plaque analysis, collab provide 46 lumen and plaque features. So the question is, what will be the benefit of the lesion level hemodynamics on top of 46 lumen and plaque features? So I also have the same question, but in all of our data, it was proven that the adding lesion level hemodynamics, the simplest metric, delta FFR across the lesion, has an additive value and better discriminating probability than having lesion level plaque analysis alone.
BK, this is very compelling for me as a clinical imager in terms of how I'm currently practicing my interpretation of coronary CT. Emerald and Emerald 2 seem to make a very compelling argument that the addition of physiology and perhaps a AI-based model for physiology and plaque evaluation will incrementally improve my and other imagers' ability to identify those scary culprit lesions that may cause horrible events downstream for our patients. So, with that in mind, do you think that the learnings from Emerald and Emerald 2 are enough to move the needle for all of our clinical imagers across the world and how we're interpreting CT today?
I have to say that it's still at the stage of hypothesis generating, so we need more data. But unfortunately, we do not have that many studies that will analyze plaque and hemodynamics together. But several trials, Emerald 1, Emerald 2, or Destiny trial, all showed the benefit of the combining and imaging and physiology. And the beauty of the CT scan is in the cath lab, if I really want to do a combined image and physiology analysis, I have to use $2,000 pressure wire and $2,000 in Korean that cost $2,000 IVUS or OCT catheter, so that it's very expensive assessment for one plaque analysis. But CT scan, if you have some interest and if you use the kind of system, you can do a very integrative lumen plaque quantity, quality, and also hemodynamic analysis. And now it's possible to analyze all these things with the help of the AI-derived tool, so that in the cath lab or interventional cardiology societies, it's very easy to say that if you have both imaging and physiology, you will have a better prediction and you can select a better treatment strategy. But tomorrow, no one will do that because of cost issues and time-consuming issues, and these are all invasive procedure that would increase the procedure risk to the patients. But CT scan, you have images, and adding some systems and softwares and interpretation, you can have all those valuable information at once. So why not?
Well, I think now is a good time then to transition to talking about what the future of this realm of science is going to be, both in the diagnostic and the therapeutic space. What would you like to see in terms of the science behind non-invasive physiology and plaque evaluation before we start to consider this as perhaps the standard of care for how we interpret coronary CTs?
Yes. So first, we need more data, and there are something we need to investigate in the future is that in all studies, we are providing the p-values and hazard ratio or odds ratio to say that this is better than that way. But while treating and assessing the individual patients, I think that we need a kind of a individualized or tailored approach to individual patients I'm looking at and I'm talking with. So that in that case, the beauty of using these AI based and machine learning analysis is not only for the analysis, but application of the results of individual data to the decision making and risk assessment. So, for example, in the MRO2 trial, we provide the explainable machine learning analysis concept to using all these prediction models, which show that if you have one patient who have a vulnerable napkin ring sign, plaque burden 70%, and lumen area 3.5, delta FFRCT at 0.11, it's very difficult for me to even integrate all these information at once. But if you simply enter those information onto the computer using the explainable machine learning analysis, you can have a individual risk of those plaques so that you can select the treatment strategy for those patients. And another very important element, which also was shown in the MO2 trial main paper, was that the time dependency of our risk prediction. So it was good that and it is natural that if we predict the 1 year event, so we can do a good job. But after 1 year, 2 year, 5 year, our prediction ability will get less and less. But we proved that the even overall decreasing of our prediction ability, no matter what kind of feature we may use during the 3 year time interval, but the benefit of the adding AI QCPH persists. So that's a good thing. But second thing is that we need to provide the relatively short-term risk and the long-term risk, because that we are not simply giving one drug and one decision and no follow-up. We are doing a follow-up so that if we have a patient with the short-term high risk, we can do early preventive PCI or the very strong medical treatment. But if you have a patient who have a low short-term risk and high long-term risk, the best thing is that we can do another follow-up CT scan to reassess the plaque characteristics and lesion characteristics, so that those are the key elements, I think, that we have to investigate more to provide a more definitive and more individual or tailored treatment provide.
Yeah, BK, I think you've outlined a great rationale, and even honestly, you've outlined the design for how we would like to bring these types of scientific studies to the forefront now. And hopefully these are either being conducted or about to be conducted, because they would really aid in our method of both patient and lesion specific evaluations of potential culprit lesions. And with that in mind, I do want to start zooming out to a more practical perspective, as many of our listeners out there are clinical imagers. We often identify these concurrent derangements in physiology and at least qualitative plaque morphology abnormalities when they're concurrently found in a single lesion or a single patient. Do you have any advice to our listeners in terms of a practical approach to both reporting and potentially managing these patients?
Yes, that's a very difficult question to answer now. But I'm thinking, so one very simple metric is that let's do a kind of 2x2 approach. So there's a plaque both negative, and there's a lesion or plaques 1 positive and 2 positive. And as Praveen, you just illustrated that the both positive has the high risk for future ACS. So if the patient have a both positive, I think you can send the patient to the interventional cardiologist to do a kind of a preventive PCI. But I have to say that plaque positive, it should be both quantity and quality positive. So there can be a lesion with the high plaque burden, small lumen, but non-vulnerable plaque. And there can be a lesion, large lumen, small plaque, but vulnerable plaque. But that may not be enough as a plaque metric. So that if the plaque has a quantity positive, quality positive, hemodynamic positive, as of today, I think I will seriously think about performing revascularization for that patients. But one very important thing is that we know that you know better than I do that there are lots of data, especially from CT data, that show that the regression of plaque. So even if it's lumen positive, plaque quantity positive, plaque quality positive, and hemodynamics positive, if it regress in a year, why should we do a preventive or prophylactic PCI? So I think that's the very important concept. As you, a CT specialist, I'm a simple-minded interventional cardiologist, simply thinking about, okay, I can do the PCI and I can do a very nice stenting, imaging guided. But as you provide me the concept of plaque regression, now I'm seriously taking the point whether this plaque will regress in a year or 2 years. And very interesting concept or discordant concept between CT specialist and interventional cardiologist is that we believe that the vulvar plaque should be the primary target for the PCI. But what I learned from CT studies and CT specialists is that the vulvar plaque is the most high probability plaque that regress. Stable plaque do not generally regress, but the vulvar plaque regress. So that having those concepts should be integrated in the future. Those time factors should be integrated in the future to define the definitive treatment. So in that perspective, even though I'm an interventional cardiologist, I now strongly believe the benefit of the guideline directed or very intensive LDL cholesterol management to prevent the future cardiovascular events.
BK, I feel like we could talk for hours about this cutting edge and oftentimes controversial set of topics here.
Yeah.
I do, however, want to start to bring our conversation to a close and ask you if you have any final thoughts about Emerald, Emerald 2, or just the general space of coronary physiology and plaque pathobiology.
Yes. So first of all, I thank you for the invitation for the great time to discuss about very deep issues. And I still believe that the current tool or the isolated analysis about lumen plaque quantity and quality in hemodynamics is not enough. And for general population, combining of these 18 features, 46 features is practically impossible. But as we have AI tools and as we have several nice machine learning based analysis tools, I think the future will be there. So if we simply open our mind and think about what will be the best for the patients, I think it's a kind of natural combining the information on lumen, plaque quantity and quality, and hemodynamics. It's not about which is better, but it's about how we can care the patients better, not implanting too many stents in terms of prophylactic stent implantation, and do a best medical treatment. And I think that will be the future. And I'm proud to say, with the help of these so many collaborators in the world, that we put some kind of a stone for the future progress, and hope that the audience and other investigators can provide the more information and more insights on top of these basic results.
BK, fantastic concluding thoughts. Really, really appreciate it. And from me, from the entire community of cardiac CT and cardiovascular medicine, really appreciative of your expertise and contributions to the science, and for coming onto the podcast to share them. So thank you.
Thank you. Thank you.
Of course. Thanks again, BK. For our listeners out there, Dr. Bonquan BK Koo is our lead esteemed guest today. He's one of the lead investigators in the Emerald and Emerald 2 studies, and I strongly encourage you all to get your hands on the papers and read them. I'll link them in the podcast description. To our listeners, of course, thank you for tuning in. If you like the content that you hear, please rate, review, and subscribe to us. That helps others out there find this amazing content from Dr. Koo and others like Dr. Koo. So to everyone again, thank you very much. As you all know, this is the Donut of Destiny. Cheers.